Perfect. Okay, so we're going to go on a bit of a journey today. You're going to get very tired of the format of my slides and the data I'm presenting, but bear with me. I am going to be chatting about healthcare visits due to cannabis and how they've changed after legalization. And I think as we talk, I think that, I have a couple of key points that I want to get across. And the first one is probably that legalization. Sorry. There you go. Okay. Legalization's been a process. It's not this one-off event. And, similar to what Dr. Hammond was talking about yesterday, there's a lot of nuance to the policy here. And we're going to get into it, but there's a variety of different paths that non-medical legalization can take. And all of them have different health implications and different policy implications. And to, simply say, legalization, it's a yes-no thing, and these are the events that occur after it, is very simplistic. My research has been funded by CIHR and CCSA, and I have no other conflicts. I've got it. All right, so we're going to talk about how the retail market has evolved over time after legalization. I'm going to briefly cover 9 studies looking at a variety of health harms. And then throughout that, we're going to contextualize them by how the market has changed, and then we're going to get into some policy discussions. So I do, again, on this theme of legalization as a nuanced policy event, you can start with decriminalization, which is getting rid of the criminal penalties for drug use and possession. And in that case, you usually would still have civil fines or civil penalties. You can move to full legalization, where you've gotten rid of those civil fines and penalties, and then you can get into commercialization. And commercialization is the idea that you're not simply legalizing the substance, but you've set up a commercial market. And within commercialization, you can have a variety of different pressures, but it's efforts to actually increase the sale of cannabis or another substance, and that's through retail availability, new products that come to market, marketing and promotion. And we, of course, have lots of experience of commercialized substances, including tobacco and alcohol, and both have, different policy frameworks in the country. In the lead up to legalization, this is the task force that was looking at it, came up with this nice schematic. If you look here, the idea is that you range from a variety of different harms, and that if you have total prohibition of a substance, you have maximal harms. And as you move across into an unregulated commercial market, you once again experience maximal harms. And the idea is you're meant to have a sweet spot of regulation in the middle, where you have legalization as tight regulation, and that would minimize harm. And there's an acknowledgement that, both alcohol and tobacco, and much more so alcohol, should be shifted more into the tightly regulation. And, alcohol is particularly under-regulated in Canada and other high-income countries with strong evidence about the detrimental harms of that. I'm going to argue that we may not have reached our strict legal regulation with cannabis. There are many things that have gone okay. There are many public health-oriented regulations in place, but in many cases we have received or achieved some degree of commercialization. So this is, just to start you off, this is some data from Statistics Canada. It's based off self-reported household spending. I say estimated here because, you have to estimating the illicit market is quite tricky. But if you look across, we see, so you have the black line is showing the total cannabis sales, the red line is showing estimated illicit spending, blue is legal, and gray is medical. And what I'd emphasize to you is that after legalization, in the early period, the rate that the estimated illicit market was declining and the legal market were growing was very similar. And starting in early 2020, the legal growth starts becoming faster than the illicit contraction. And again, with caveats, the estimate is that the growth of the legal market has been twice that in value of the illicit market. And it's spending, people may be purchasing more expensive products, but this probably suggests that there's a net increase in cannabis use in the country after legalization. And no real shift in medical cannabis either, which is interesting, but not something I'll dive into. Again, here's some changes. Here's a study we did on changes in the legal market. On the left, you see the number of stores per 100,000 people in the country every 6 months. We see enormous increases over time, which is everyone's lived experience of here in Ontario of seeing the proliferation of stores. Provinces that have a government-regulated system, like Quebec, have seen far more gradual increases in the number of stores than ones that have opted for a private system. 4 years out from legalization, Alberta has over 20 stores per 100,000 people. Quebec has 1.2. So you're talking almost a 20-fold difference. So the methods so this is the background methods for all the different studies. It's using health admin data. It's what we term population level data, so it captures every healthcare visit through our universal health system. It's going to focus mostly on Ontario. And then what we do is we look at visits due to cannabis, and this is a place where you use an ICD-10 code, which is a system of disease classification, and you look for a code where the treating team said, a main or contributing reason for this healthcare visit was cannabis use, and across a variety of different types of cannabis harms. The first topic that we're going to do is pediatric cannabis poisoning. So in the lead up to legalization, the experience in Colorado State had certainly been that there had been an uptick in poisonings in very young children. Canada was concerned about this and put in a series of regulations. We had child-resistant packaging, maximum THC content. We phased the roll-in of cannabis product, and the idea is that we would hopefully avoid these types of increases, and we're going to see how we did. And the phased introduction of these products is really key. So on the onset of legalization, you had flower only, some seeds, you could grow your own stuff, a little bit of oil. And then 1 year later, companies could submit for approval to start selling edibles amongst other products. And those come to market in December or January, December 2019, January 2020, depending on the jurisdiction. Importantly, we're going to look at 4 different provinces, the 4 most populous provinces. Ontario, Alberta, and BC let a wide variety of products come to market. Quebec, over concerns about appeal to youth, said, we're not going to allow the sale of chocolates, candy, anything that we think could be appealing. And this is, I think Dave Hammond showed the kind of cannabis-infused cauliflower yesterday from Quebec. But again, this is what's on offer at the Ontario Cannabis Store. You have a wide variety of products. Once they are out of their packaging, they are arguably indistinguishable from candy with high appeal to youth. And in Quebec, you have dried fruit or cannabis powders that you can put on top of stuff. And actually, during our study period that we're going to talk about, even those products hadn't come to market. So this first slide is looking at emergency room visits for cannabis poisonings in kids aged 0 to 9 in the province of Ontario. We're going to start. I'll spend a bit of time here so that you get oriented to how these slides work, but it's time series data. So you start in January of 2016. We head all the way to March 2021. Across the studies, the timeframes are going to change because we kept doing them and we got more and more data, or we realized that you had to go back further. But generally, we go time as we go along. We're looking at 3 periods: the pre-legalization period, period 1 when you have flower product only, and then period 2 when the edibles come to market. And what you see is that in a crude, not time-adjusted way, during period 1, the average rate of these cannabis poisonings in young children is 3 times higher than the pre-legal period, and during period 2, it's 9 times higher. There's 512 emergency room visits in this study, so they're a relatively rare event, but they're quite severe. And what we saw is that not only was there a 9-fold increase after legalization, but that kids became more likely to have to be admitted to hospital. You went from 25% to just under 40%. Some of the challenges and critiques that came out of this research was that, one, the increases, and we're going to address this on the next slide, but the increases were caused by increased parental willingness to disclose cannabis use. The next idea was that they're not real poisonings. It's kind of like an exposure. The children are fine. That the poisonings may be related to the COVID-19 pandemic, which, as we're going to talk about today, overlaps with much of the later legal periods, and that the poisonings are arising from illicit, not legal products. And to address some of these concerns, we did a follow-up study. So what we've done now is we've leveraged the natural experiment from the fact that Quebec said that these products won't come to market. We've switched to hospitalizations because that's what is uniformly available across the country. And again, we see a fairly similar pattern. The visits are increasing and slightly in the lead up to legalization. In period 1, when there's no edibles, it goes up 2.6-fold for all 4 provinces. So Ontario, Alberta, Quebec, British Columbia. When the edible products come to market, Quebec receives no additional increase and the other provinces have a further increase. Now, these are very severe poisoning events. These are children who've been admitted to hospital for a cannabis exposure. And this is in the middle of a global pandemic when no one wants to admit children to hospital. To the point that they're not severe events, children can die with a poisoning exposure, primarily from respiratory problems where they'll stop breathing. So many of these children are intubated and require ventilation in the ICU, or they're receiving supplemental oxygen and a series of interventions. The idea that this is a change in disclosure has the potential to explain some of the changes in the first period. But again, cannabis gets legalized in period 1. There's no reason for parents to suddenly start disclosing cannabis more often 18 months after that, and for them to do it differentially between some provinces and others, or there's much less of a clear rationale. Similarly, the control group that we have here, Quebec, is arguing strongly against the idea that this is a surge in illicit products. Quebec has an illicit cannabis market. There's been numerous reports about children in Quebec poisoned by illicit cannabis products. So I think that there is arguably a big contribution of the new legal edibles that have come to market and that are resulting in these poisonings. Certainly the higher, the THC dose that we have, 10 milligrams, is protective for these poisonings. It makes them less severe, but we'll get into it at the end. There was a recent paper showing that the kind of severe toxicity threshold for cannabis in young children was 1.7 milligrams per kilogram. So what it means is that if a young child eating 2 or 3 of the legal edibles at 10 milligrams of THC can get into a lot of problems and need to have respiratory support or fluids or monitoring in the hospital. And the other idea, so COVID. So again, everyone kind of experienced COVID together. There was some variations. Ontario and Quebec had a fairly similar pandemic experience. And we actually looked at changes in other types of poisonings. Nothing else went up during the pandemic. The only thing that rose was cannabis. So as we wrap this up, the frequency and severity of poisonings due to cannabis in young kids have increased after legalization. The legal edibles are probably contributing to it. This occurred despite regulations we put in place, like child-resistant packaging. At this stage, 40% of hospitalizations in this age group for poisoning are actually due to cannabis. So it's become the leading cause of poisoning hospitalizations. And this is, I'm gonna say, is probably the strongest evidence of an adverse health impact. Everything else is gonna get a little bit murkier as we go along. And it could get worse. We have a legislative review right now. There's discussions about removing some of the THC limits, and I would argue that that would be a mistake. We're going to switch. Now we're going to be looking at healthcare visits, mostly in Ontario. We're going to do one study nationally, and we're looking at adults, and we're going to track changes in emergency room visits and hospitalizations related to cannabis use. We're going to look at overall visits. We're going to look at cannabis-induced psychosis, hyperemesis, and then we're going to look at some special populations, so treatment for cannabis use or cannabis involvement during pregnancy and during motor vehicle collisions. And again, we're going to contextualize it all by the changes in the legal market. Just a quick dive into what happened in Ontario. Many people are probably familiar. We legalized cannabis in October 2018. The initial period is very constrained. You have no stores. You can only buy cannabis through a government website. There's product shortages. It's flower only. Eventually some stores open, but you get 67 for the whole province. And then starting in early 2020, new products come to market, which we discussed, and the cap on the stores is removed. And you go from 67 stores to 1,950 just a couple days ago. And this, of course, overlaps with the pandemic, which is going to create some challenges. But the market is rapidly expanding. It's expanding in sales. It's arguably increasing net cannabis spending, so more people are using and purchasing cannabis than they were before legalization, and that this is not a one-to-one replacement of the illicit market. And here's just, again, some time series about how the sales in stores have changed over time in Ontario. So we see that during the initial legalization phase, the orange dots are per capita sales and the blue bars are per capita stores. During the initial legal phase, where it's very restricted, you have almost no sales. During the period of time that some of the product shortages resolve and you get a couple of stores, that gets up to the line. The line is in the wrong spot. It should be a year earlier. But you does this have a pointer? No. Okay. So the product shortages, the retail store cap gets lifted and you have an acceleration in stores and sales. And the market continues to grow. We actually, the stores have started to equalize in Ontario where they're closing at around the same rate that they're opening. So we may be reaching kind of store saturation, but the sales continue to rise slowly over time. Here's changes in emergency room visits due to cannabis overall in the province of Ontario between 2010 and 2021. We're going to look at a couple different policy periods. So, we've got before non-medical legalization, the first intervention line is showing around the time that access to medical cannabis is increased and the government, the newly elected Liberal government announces that they're going to legalize non-medical cannabis. And if you actually, and this is called an interrupted time series, so you look for changes in how the rate is changing over time, which is called a slope change, and a level change where the regression allows the kind of the average to jump or decrease. So visits were increasing pre-announcement that cannabis was going to be legalized. They accelerated after that announcement, probably during a period of increasing access to illicit and medical cannabis. And then interestingly, after the restricted legalization period in Ontario, they actually stop increasing and they plateau. And then during the period of time that the pandemic occurs, which is also when the market commercialized, you get a jump. You see the same pattern in people. We're defining youth here as 15 to 24. We're going to redefine them in later studies. And then adults are 25 plus. But this is everyone aged 15 to 105. And again, these are all emergency room visits for cannabis. So cannabis-induced psychosis, cannabis use disorders, intoxication, poisonings. So some challenges here, again, are the changes from increased willingness to disclose cannabis use or increased clinician awareness of cannabis use and documentation. Are these changes from commercialization, or are they from the COVID-19 pandemic, or are they from both? And we're going to get into that in some later studies where you try and tease that out. We're going to look specifically whether the changes impact people above and below the minimum legal age of purchase in Ontario in the same way. And we're also going to look at changes contextualized by other substances, which is very tricky, but maybe gives us some information. So here we did a follow-up study. We're looking at cannabis hyperemesis syndrome. So this is a condition that people who use daily high-potency cannabis can develop, where they have very severe vomiting, nausea, and often end up in a emerge, very unwell, dehydrated, and have very severe pain. They get a lot of interventions and assessments. They get CT scans. They might get treatments, and it can be very challenging for people. In this study, we're defining it as a combination of someone who's visited emerge for vomiting, and they also have a co-diagnosis of a cannabis code with them. Similar patterns. You see that they're increasing in the lead up to legalization. After legalization, really there's not a change. That pattern of increasing visits over time just continues. And then during the commercial COVID period, there's a jump. And interestingly, we see that the jump occurs for people aged 19 to 24, but not for people aged 15 to 18. So individuals with access to the legal market during this period see an increase in visits. People who are age gated out of it do not see that increase. And then on the bottom slide, we look at per substance use. So compared to, again, even if as you adjust for other types of substance use, so alcohol and opioids and cocaine, the increase in these cannabis visits is much larger than the increase or change in those visits, similar for visits for anxiety or depression or psychosis. So a couple of signals saying this is, it maybe there's a legalization impact and maybe there's also a COVID-19 impact. Tough to disentangle the two. And maybe it's interacting, that the pandemic was going to increase cannabis use, no matter where you are, but that if you have a legal market which is expanding at the same time, it's going to increase cannabis use and harms more. Very quickly, we replicated the study, same types of visits, and this is looking at hospitalizations due to cannabis for the four most populous provinces in Canada, and we see the same pattern that, it's pretty much true across the country that in the lead up to legalization, hospitalizations due to cannabis are increasing. During this restricted legal period, they stopped increasing, or they actually might have declined slightly. And then during the commercial COVID period, they started increasing again or had a sudden increase. I'm not quite sure what was happening in British Columbia. That's the top right corner. They actually declined quite significantly during the restricted legalization period. And again, it's hard to exactly tease it out, but provinces like Ontario and British Columbia had a pretty slow start to their legal markets. Alberta had a quick start and rapidly expanded. In Quebec, while it didn't rapidly expand at the start, their market has grown far less over time than the other jurisdictions. So a bit of a trend that the regions that had a larger legal market at the onset of legalization saw less of a decline during those periods. One other thing to highlight, and we're going to get into this on the next couple of slides, is that the biggest increase that we saw in this study for hospitalizations due to cannabis was hospitalizations for cannabis-induced psychosis. So if you look at the rates that are in the pre-legal period and the rates that are in the commercial or COVID-19 period, just the average, so no time series component, those have gone up 40%. And we're going to talk about, some of the implications of that as well. So, my takeaway is that all these visits, a variety of health harms were increasing well before legalization, as far back as 2010 or 2008 in other studies. They've differed by the policy periods. There's been some subtle changes where maybe they accelerated after the announcement that we were going to legalize cannabis. They plateaued in the restricted market. They accelerated or jumped again during the commercial or COVID period. But the basic trend is that the visits are going up, that this is an increasing health concern. And if we go back, I think in other explanations that you might have for this is certainly, there's probably increasing detection over time. Clinicians are becoming more aware of some of these harms. People are more likely to disclose as the social norms about it change. But I don't think that's fully explaining what's happening. And this is consistent with the idea that we have lots of survey data about people saying they're using more cannabis over time, over these periods. And again, if this was being driven by changes in self-report or clinician documentation, you'd see those changes after the initial legalization. You wouldn't see them, a year and a half or 2 years later as the market's commercializing. So I don't think, other little things, there hasn't been big coding changes. Everyone's using the same coding scheme for emergency room visits in Ontario. So lots of other biases or alternative explanations are certainly not fully explaining the trends that we're seeing. And I think that, I really do think that there is some contribution of the commercializing legal market, and I think that we need time and further monitoring to understand the long-term impacts. But as we look at these changes, I do think that legalization has done something. But again, if you get rid of all these policy periods, you don't say, we're looking at the restricted or we're looking at the commercial, just the general graph is showing these visits are solidly increasing over time. And that makes an argument about, what should we be doing from a clinical and policy perspective. So cannabis and psychosis, we're going to cover a study tracking changes in cannabis-induced psychosis in Ontario, and then we're going to talk about what happens to people who have an episode of cannabis-induced psychosis. Very similar graph, emergency room visits for cannabis-induced psychosis, increasing pre-legalization. They stop increasing to the same degree or plateau during the restricted period, and then start increasing again during the commercialization period. We, in the full study, we looked at changes in other substance-induced psychosis, which did not increase during commercialization. Same patterns about age, where they went up for people above the legal age, but not up for people below the minimum legal age. Just to give you a scale, in the whole emergency room visits for cannabis between 2010 and 2021, we're talking about around 120,000 visits. Maybe 20,000 of those visits for cannabis hyperemesis. Here we're looking at 6,300 visits for cannabis-induced psychosis. One of the very concerning features to me is that we looked at first episode psychosis or first presentation psychosis. So these are people who have no history of schizophrenia, they've never had a substance-induced psychosis, they've showed up in Emerge, and it's their first time in Emerge for psychosis. And the proportion of those that are associated with cannabis in Ontario have doubled over time. So it went from just under 4% to 8% in the commercialization period. Now we're going to use a study in Ontario. We're looking at just under 10 million people. Everyone living in the province who's between the age of 14 and 65, or 65, between 2008 and 2022. None of them have any history of psychosis. They've never been treated for schizophrenia in an outpatient emergency room visit or hospital setting. They've never had a substance-induced psychosis before. They don't have bipolar disorder at baseline. And again, this doesn't mean that they don't have one of those problems and have never sought healthcare for it, or that they're kind of on the early phase of one of those disorders and are going to develop it shortly. But they've certainly never received healthcare in Ontario for one of those conditions. And then we looked at everyone in the province who has a first presentation for substance use. There's 400,000 of them, just under 13,000 are for a substance-induced psychosis. And then we're going to see what happens to individuals and their risk of developing schizophrenia or a schizophrenia spectrum disorder. And that's again determined by emergency room visits, hospitalizations, or outpatient visits for schizophrenia. So we have, so I think the key takeaway is that if you look at all substance-induced psychoses, within 3 years of a presentation, around 18% of people will develop schizophrenia or be diagnosed with schizophrenia. For cannabis-induced psychosis, that's 26% within 3 years. And in the general population, we're talking 0.1%. So if you look at the hazard ratios, so this is you're saying, compared to someone of the same age and sex as you, who in the general population who has not had an episode of substance-induced psychosis, if you've had any type of substance-induced psychosis, you have 160 times the risk of developing schizophrenia within 3 years. And for cannabis, that's 240 times the risk. What we looked at too was people who've had an emergency room visit for substance use without psychosis. So someone's there in withdrawal or they've intoxicated, but they're not having, and I should define a substance-induced psychosis. So that's someone who's shown up in Emerge, they're having paranoia, they're having visual or auditory hallucinations, or having psychotic features or a detachment from reality. And that's related to either the acute intoxicating effects of the substance or the withdrawal from it. And typically those resolve with time. That's why it's not a chronic psychotic disorder. So over a matter of days or potentially weeks, people will return back to their baseline. And so that's the substance-induced psychosis group. For the substance use without psychosis group, we're looking at people who've showed up in Emerge, maybe with a panic attack and someone was saying, you recently used cannabis, or they've showed up in Emerge and someone says, I think you have a cannabis use disorder, or you seem very high right now, but there's no psychotic features. And what we see is that this is a much larger group, and their risk of developing schizophrenia is much lower. For cannabis, it's 14 times the general population, but there's a lot of them, and they end up, a lot of them, in absolute numbers, will end up transitioning to schizophrenia. I think you get 1,300 within 3 years of their presentation, or just under 2% for cannabis. There's very interesting age-sex interactions. So just to orient you here, we've got the risk of transitioning. It's just a crude percent within 3 years of your emergency room visit. We're looking at men and women of different age categories. And on the far right, we're looking at cannabis-induced psychosis, substance-induced psychosis without cannabis, cannabis without psychosis, substance without psychosis in the general population. And what I'd highlight here is that the risk of cannabis, the mental health implications for chronic psychotic disorders vary enormously by age and sex. And again, you see that for men aged 14 to 24, within 3 years of an episode of cannabis-induced psychosis, just over 40% of them will develop schizophrenia. It's a very high number, much higher than other types of substance-induced psychoses and much higher than the women, who are around 20%. So there seems to be a signal that cannabis use is particularly risky, particularly risky for young men, and with significant interactions here. And so, as we talk about the psychosis, again, I would say that there's pretty compelling data that episodes of cannabis-induced psychosis have been increasing over time. We can have debates about, again, the different legalization period, but the absolute increase, these visits have gone up 200 to 300% over the last 7 years. They are associated with a very high risk of developing schizophrenia. And when you combine these two things together, I think we have unclear long-term implications of whether the prevalence of chronic psychotic disorders are going to increase caused by cannabis use in Canada. The average time between initiation of cannabis use and the development of schizophrenia is around 6 years. So again, if we go back to some of the data that was presented yesterday about how cannabis use has been increasing, for people who are newly initiating cannabis use, which we seem to have happened in 2019, 2020, and 2021, if those individuals are going to develop schizophrenia because of their cannabis use, we're probably not going to see those effects until the mid to late 2020s. So, it really emphasizes that you look at the first 5 years and you can get, some indication of early signals and some signs about what the acute effects have been. But if you want to track more chronic and long-term effects, both from a developing legal market and from some of these health outcomes, you need to have a much longer time frame to look for it. We're going to talk about cannabis use during pregnancy, and then we're going to look at mode of traffic injury, emergency room visits with cannabis involvement in them too. So the first study, we're going to look at emergency room visits or hospitalizations due to cannabis while people are pregnant. We're going to study 1 million pregnant people in Ontario over time, and then we're going to compare pregnancies where there was treatment for cannabis use during them to pregnancies without. We're going to adjust on a variety of factors, and we're going to see what happens to the babies. So again, we see that and again, we're looking at quarterly data instead of monthly data because these outcomes are very, very rare. We're talking about 540 pregnancies. But the number of pregnancies that have required treatment for a cannabis use disorder or cannabis-induced psychosis or cannabis poisoning in the Emerger Hospital has doubled since legalization. It's gone up 80%. It's a trend if they just increase over time after legalization. They weren't really increasing in the lead up to legalization. And again, I'm not showing it to you, but we looked at treatment for other substances during pregnancy and other mental health concerns, and those have not increased over time. When you look at pregnancies that have had treatment for cannabis use during them and you compare them to pregnancies that don't, and again, you match on, or you adjust for age and socioeconomic status and pre-pregnancy health conditions like diabetes and hypertension and asthma, you find that you have around a doubling of a variety of adverse events. So the kids are more likely to be admitted to the NICU in the first month. The kids are more likely to be born premature and to be born in the lowest 5th percentile of birth weight. Huge unmeasured confounding in this study. You should not look at this and say this is a causal study saying that cannabis use is causing these adverse outcomes. This is health admin data. We have no access to details on things like smoking, which are almost certainly higher in the population who's receiving treatment for cannabis use. We've got a good sense that they have similar patterns of mental health disorders and chronic conditions, but we don't have a sense that their behavioral risk factors are similar, and they're almost certainly not. I would look at this, though, in the broader literature where there is growing evidence that cannabis use during pregnancy, and these are different types of studies where you do have, individual level risk factor data, is associated with a variety of short and long-term problems, including neurodevelopmental outcomes, increased risk of autism spectrum disorder diagnoses, And I think is part of the, the evidence that there is lots of uncertainty about the health impacts of cannabis during pregnancy. As a precautionary approach, it is, and this is endorsed by major obstetrical societies, people should avoid cannabis use during pregnancy. We'll talk about the emergency room visits for traffic injuries and cannabis use, and then we'll wrap a discussion on cannabis in pregnancy and cannabis in traffic injury and ED visits, because they have similar caveats. So here we're looking at people who've been injured in a motor vehicle collision, or they're a pedestrian, or they're a cyclist, and they've showed up in Emerge in Ontario. And we're gonna track amongst all these emergency room visits, which ones have a co-diagnosis of cannabis use. And we were motivated to do this study because there'd been a bunch of studies looking at total motor vehicle collisions after legalization, and the signal was that they were the same or down. And again, my comment is we just lived through a global pandemic when people were driving 75% less. Everyone was at home, no one was on the road. So to say, hey, everything's fine, there's been no increase in car collisions, there's been no increase in insurance claims for car collisions, is really not a great way to look at this problem. This has many limitations, but the emphasis that I want to say is the signal is that it's very unclear what the road safety impacts of legalization have been, and that we shouldn't be reassured by no net change in car collisions. Again, so on the left, we've got traffic injury ED visits with cannabis involvement, and on the right, we've got traffic injury ED visits with alcohol involvement. And again, a story of increasing over time. If you look at the rate between 2010 and 2021, 2021's there. They've gone up by just under 500% cannabis involvement, and I think that alcohol involvement changed by 20% or 15%. Really, again, they seem to start increasing in 2015 or 2014 during that time of medical liberalization and changing announcements from the federal government. They may have jumped during commercialization. Tiny number of visits, we're talking 426 emergency room visits over this study with cannabis involvement. Very nice data from researchers out west who have studies where they look at blood levels of THC. In injured drivers, it's automatically collected data, so there isn't response bias. They've seen that people at who are over the legal limit set by the companion bill to the Cannabis Act, that's doubled the blood concentrations of THC after legalization. So part of a picture of people aren't necessarily reporting increased cannabis impaired driving on surveys, which is an interesting thing to disclose given that it's illegal. But there's been some markers about increasing blood serum THC levels. This is saying that the judgment of clinicians in Emerge is that there seems to be more cannabis involvement. Little biases. There was, the police got new powers to do drug testing after legalization. That does not occur in the emergency room. That occurs at police stations. So biases like that aren't impacting what we're seeing here. But undoubtedly, some of this change is from growing awareness about cannabis impaired driving over time. And again, I don't think that someone who's showing up in Emerge is disclosing that they used a substance because it's illegal and would have implications, or they're not commonly doing it. And you see in this data that the people with cannabis involvement in their traffic injury ED visits, 80% of them come in by ambulance. So these are quite severely injured people who are not necessarily coming in by their own choice. They may have, and I think 50% get admitted to hospital, 20% go to the ICU. So a very severely injured group who are probably not coming in and saying I used cannabis. It's part of more of a an investigation, and clinicians were quite concerned. So to wrap pregnancy and the traffic injury ED visits, cannabis involvement in pregnancy and traffic injury ED visits has risen over time. They're exceptionally rare events. You can only infer, they're interesting not because there's 540 people who receive treatment for cannabis use disorder during their pregnancy, but because they may reflect much broader societal changes in cannabis use during pregnancy. Same thing with the traffic injury ED visits. And the degree to which that does, it undoubtedly reflects more people. There are more people who are using cannabis during pregnancy than 540 people in Ontario. but the degree of that kind of being the tip of the iceberg is unclear. And you need, again, this is just an area where you need different types of data and better data. And I talked about it. I do think that there is a concerning safety signal for cannabis use during pregnancy, and we'll get more data on it over time. But it's part of a growing sense that cannabis there's been lots of studies about cannabis being used for treatment of morning sickness during pregnancy, and we actually saw that in our study. There was people who required hospital treatment for morning sickness during their pregnancy. I think we're at 13 times the risk of also having treatment for cannabis use during pregnancy. And the morning sickness occurred most of the time before the cannabis use. So again, it could be a part of a signal of people are having symptoms of mental health problems or morning sickness during pregnancy and are self-medicating with cannabis. Okay, how are we doing on time? We got like 4 more slides, 15 minutes, thank you. So my first comment about legalization is that legalization with strict controls has not accelerated the pre-legalization trend of increasing cannabis harms, may have plateaued it. And in all of this, there are substantial public health benefits of changing the way cannabis was enforced from a criminal justice perspective. And we'll look at that on the next slide, but I would argue that you can get all those public health benefits from stopping giving criminal records to youth who are, which was well documented to be very racist, which is an enormous public health problem in itself. You can get all of those benefits through legalization with restrictions. Yes, you probably don't even need to legalize. You could just decriminalize cannabis and change drug enforcement and get all those public health benefits. You do not need to sell cannabis-infused chocolates or cannabis-infused figs or shatter or concentrates, all this stuff. You don't need to do that to stop criminally prosecuting Black and Indigenous youth for minor cannabis crimes. And again, here's the police-reported cannabis crimes in Canada, and we're looking, this is from Statistics Canada from 2006 to 2021. They're in decline well before legalization as part of, shifting police priorities and drug enforcement. They certainly accelerate after legalization, but again, they've plateaued. They haven't gone further. You could make an argument that, much of the efforts of legalization should have been saying, hey, this is no longer something that we in society think should be a crime and give people a criminal record for. Let's offer amnesty for all of the individuals who were wrongly prosecuted in the past as a first step for public health benefits, which has largely not happened in the country. So that's the side. And I think that it could be that the net effect of Canada deciding to change the way we think about cannabis and its legality is all a public health benefit. The criminal justice harms are enormous and very hard to measure. And this may all be, net good for society compared to all the cannabis harms that I just talked about. But I would argue you could have had this maybe without some of the cannabis harms. So the policy idea too is that commercializing cannabis probably increases poisoning in very young children. It's the strongest evidence that we've seen. It's been seen in numerous countries or states now around the world. Restricting the edibles in Quebec seemed to be highly protective. They saw a 3-fold increase rather than a 7-fold increase like the rest of the country in hospitalizations due to cannabis. And I would highlight that there is a very large risk right now where the cannabis industry is asking for the 10 milligrams of THC limit to be removed from cannabis edibles. They're saying they need to compete with the illicit market. I would argue that those are products that exist on the illicit market that we should have no interest in selling on a legal market. They can stick around. I don't think that you want to sell a 300 milligram cannabis-infused chocolate bar on the legal market. The poisoning potential for youth is enormous. The poisoning potential for naive adult users is very high. And again, there's no wiggle room on this limit. If you bump it up to 20 or to 30 milligrams, a single dose will be enough to send a young child to the hospital, potentially not breathing, potentially needing, vasopressors to keep their blood pressure up. And again, this is from a study out of Colorado where they found that, this 1.7 milligram limit strongly predicted children needing to be intubated or arriving in a coma or having a seizure. And again, average 3-year-old child, and this is the calculation there. So I don't think we have much of a safety margin on the edibles. My math may be wrong. Feel free to come correct me. I think that the last policy implication, and then we'll wrap, is that the market has undergone commercialization. I do not think that we have landed at the tightly regulated legal market that was envisioned kind of in the lead up to legalization. It could be much worse. There is substantial room to further deregulate and to head more into commercialization, and we've seen wide variation across the country. I think there are some early warning signals that commercialization may increase use and harms, and we just need more time. The pandemic has put in a big confounder. The fact that the visits were just increasing over time in the first place is an interesting idea. And a lot of these harms are going to take time to show up if they do, in fact, show up. This just big trend of increasing visits over time, increasing cannabis use, we can debate all we want about what our drug policy has done to influence that. I think faced with the idea that more and more people are using cannabis and experiencing harm from it, the question is, how do you use legalization, which is certainly here to stay, and regulations through it to try and reduce some of the harmful patterns of cannabis use, and how do you reduce some of the harms that Canadians experience? Lots of people to thank, but I want to give people time to ask questions, and feel free to reach out.
We do have an online question. In any of the poisoning investigations, were there any indications of contamination of other chemicals beyond cannabis, especially in illegal cannabis events?
Yeah, so for the poisoning events, again, it's health admin data, so there's no, and this is the limit, right? There's no one saying, we looked in the chart and this kid ate 48 milligrams and it looked like it came from an Oreo from the illegal market. It's just the clinical team said it's a cannabis poisoning. We looked, none of these kids have other poisoning events. These are not co-ingestion events. There isn't opioids or antidepressants or blood pressure medications. This really is young kids who have found a cannabis-infused candy, which looks and I'm sure tastes delicious, and they eat them and they get poisoning.
Great talk. I have a specific question and a global question. The specific question pertains to the rates of driving impairment, and it looked like alcohol was associated with about an order of magnitude higher rate. I was wondering if you could sort of talk out how to think about cannabis involvement versus alcohol involvement, just because alcohol is a good control substance of sorts.
Yeah, it's a great question. So a magnitude of 10 higher. And when you look at this data, it is underrepresenting everything, right? You're talking about 7,000 emergency room visits for alcohol-impaired driving during the study timeframe. That is not the scale or impact of alcohol on driving as well. I think it's really tricky. Alcohol, clinically, you have blood alcohol levels that you can obtain easily in Emerge. People are familiar with it. The legal, the tool that you say this person is legally impaired is available in Emerge to a clinician. So they can feel very comfortable being like, I've got a number, I can attach it to the diagnosis. For cannabis, the tools that you have would be a urine drug screen, which tells about cannabis use, in the past days or weeks, depending on how people use it. So I think it's hard to know how much it's underestimating it. All of this, another big caveat, alcohol causes enormous harm in our society. It is absolutely underregulated. There are strong commercial interests that prevent effective public health-oriented regulation for alcohol. When we talk about cannabis regulation, we should be talking about, rather than saying, oh, alcohol allows more marketing and promotion than cannabis, we should allow more marketing and promotion of cannabis. This is the equalizer. Bring everything down to cannabis or bring it closer to tobacco. And maybe, does that answer your question?
It does. My broader question is whether you can help us sort of think about the rare events issue in your data, because I find all of the findings are very persuasive in terms of overall global changes and changes especially during commercialization. The reality is they are rare occurrences that are now happening at a higher rate. The proportionality is very scary. Now hundreds of percent higher, but nonetheless fairly unusual things. when we think about population benefits and harms and whether or not the policy of legalization was good for Canada as a whole, how do we factor in the rare events that are increasing relative to the common events for large numbers of people who are not experiencing those harms? And that's what I'm trying to wrap my head around.
Yeah, I think so. A lot of and like some of these outcomes, like the pregnancy and the traffic injury visits, those are the rare events. Those are like, there's 400 of them, 500 of them. I mean, there's been hundreds of thousands of people who showed up and emerged with cannabis use disorders or cannabis-induced psychosis, the mental and behavioral problems from cannabis are common. Those, it's the leading cause of substance use, ED visits, and hospitalizations in the country for youth is cannabis involvement. People are often presenting with other substances and mental health concerns, but there is a large mental health and substance use burden in youth and young adults. The rare events, I don't conceptualize them as an answer to like the impact of legalization on cannabis use during pregnancy or on road safety issues. I think that they're calling for more data. And they're saying, like, we need high quality population level surveys looking at changes in cannabis use during pregnancy after legalization. The other studies that have been done before us had enrolled 700 people in British Columbia, of whom 100 had used cannabis. And we're trying to, so underpowered, who participated in this survey? What does that tell you about cannabis use during pregnancy? So it's not definitive. And I don't look at those 540 pregnancies and go, this is the public health crisis. This is a public health or population level problem. I say, if there's been a doubling of cannabis use disorder treatment during pregnancy, and there's been a doubling of people using cannabis during pregnancy from 6% to 12%, now we're talking about some public health problems that are arising from there. Same thing with the traffic injuries. We're not capturing, we know we're capturing a very small fraction. I think 18% of moderately injured drivers in Ontario have detectable THC in their system when you look at studies that look at that. Very hard to tell the degree of impairment. Did it cause the accident? But that's a very high number. And it's raising flags.
Thank you.
Hi, so really interesting presentation and sort of a nice body of work across a number of different areas of concern. One of the arguments that I've heard when you're looking about the association between cannabis use and psychosis is individuals that have emerging symptoms of these complaints may choose to self-medicate. And so the increasing availability of cannabis may simply mean that more individuals are coming in with these patterns of use because it's something that they're choosing to use to try to address their symptoms. I'm wondering if you're aware of any studies that have shown an overall net change in the proportion of the individuals that are developing, schizophrenia, for example. Does it uptick more than 1 in 1,000 in, countries or regions where there has been increasing availability of cannabis for a number of years?
Yeah, so thanks. Fantastic question. The causal link between cannabis, the association between cannabis use and psychosis is like decades old. People have been thinking about this for, I think there's studies talking about it from 100 years ago. People have been commenting on this. So it's not a new idea. There's enormous debate about it. There's some really interesting genetic studies that have started to come out where you use like Mendelian randomization and also, whole gene sequence stuff. I will not pretend to be an expert on them. My reading of the literature is that they're supporting some causal contribution. Ongoing debate, the case is not closed, but they're saying, we've got data on people's genes, we've got data on their patterns of use, we've got some data on environmental factors, and it seems like there is some causal contribution that's here. There's been 2 studies, I can find them for you if you want. One of them was published in JAMA Psychiatry looking at changes in the population attributable fraction of cannabis on schizophrenia in a Scandinavian country. I think that it's in Denmark. And they found that the population attributable fraction, or the estimate of the number of cases of schizophrenia caused by cannabis use, has risen substantially over time in tandem with increasing cannabis use and potency in the population. And they're finding that the incidence of schizophrenia has risen to a lesser degree, but it is rising there. It's a really complicated thing to look at. You've got so many different risk factors that go into it. risk factors like being a refugee or an immigrant to Canada, which are strongly associated. And again, you can kind of adjust for these, but there's always the concern that there's other factors that are on the causal pathway to schizophrenia that are unmeasured. We may face a scenario where, 10 years from now, the population attributable fraction of cannabis use for schizophrenia in Canada has risen dramatically, and the rates of schizophrenia are pretty similar. And then we'll scratch our head and say, is this because they would have declined if cannabis use hadn't increased, or is this because they're not really linked?
All right, thank you very much.
Thanks.
Thank you so much once again for your talk. And my question kind of relates to the last question in terms of the link of cannabis-induced psychosis and schizophrenia. And I think in your studies that you mentioned that you were looking at patient histories for people who potentially have predisposition to schizophrenia. Did you look at any other predispositions to any other mental health related issues? And if also, suppose some patients don't have an immediate history of showing these like schizophrenia, bipolar, etc., but they're developed through, let's say, cannabis-induced psychosis. Are there studies showing that currently, and have you found that in your research?
Yeah, thanks, these are great questions. So, the figure that I gave you, like a 240-fold increase, that's the age and sex adjusted model. So that's saying you've shown up, compared to someone of the same age and sex as you, you're at 240 times the risk of developing schizophrenia. We adjusted for other substance use, other mental health. Have you ever seen a psychiatrist? Have you seen your family physician for anxiety before? The association drops. I think it was 80. I was trying to pull it up. I think it's around 80 when you go there. So much of it goes away. In discussions of causality, many of those factors that you adjust for are arguably mediators on the causal pathway, right? So you could argue it's over adjusted, but throwing, all the health admin data that's easily accessible at it, the association persists and it's still very large. And again, this is not the definitive study on the causality. There's been lots of good work, from a variety of disciplines, all raising concerns about the link. I think that it's definitely possible and true that there are some individuals who are having prodromal symptoms of schizophrenia who are probably going to develop it anyways, and they're using cannabis to self-medicate. Again, what the evidence shows is that for those individuals, it accelerates the age at which they get formally diagnosed with schizophrenia. And the age of first diagnosis is also a strong predictor of downstream morbidity and mortality. So someone who may have developed schizophrenia when they were 22, but now develops it when they're 17 because of heavy cannabis use, may not be finishing high school, may not be doing different things in life that were actually going to lead to a better life and reduced factors for early death and substantial social harms. So I would view it both that it's probably causing excess cases of schizophrenia and it's accelerating the development of it in people who are predisposed.
Okay, thank you. Also, you mentioned it's a very difficult link with increased legalization of cannabis and the pandemic. How can you adjust for the pandemic happening and how much the pandemic has impacted mental health across the globe in these studies?
Yeah, we're using like an interrupted time series, which is like the model underpinning of all of this, is considered, one of the gold standard natural experiment designs. Very good at dealing with what you'd call competing. It's very good at dealing with like the past, so like pre-intervention trends. Very bad at dealing with competing events like the pandemic. So you see a jump, the model itself tells you nothing about, and if they overlap exactly, it can't tell you which one of the two did it. I think the data that supports some commercialization contribution is the idea that, the increases in cannabis use were bigger than other types of substance. That again, we see the people who could access the legal market, who are 19 plus, see changes. People who are, too young to purchase on the legal market don't see changes. Ultimately, this is a scenario where you just need to look further. Pandemic's done now. It is, new variants aside, I think that is an area in our past. And now we get to see what happens when you have a fully commercial market and you don't have a pandemic. And if the visits start coming right back on down, I'll be convinced that it was COVID and that this was not legalization. If the visits continue to stay high or they go higher and higher, you're really getting more and more evidence that this is probably something related to the policies.
Perfect. Thank you so much.
Thanks.
Hi, thank you. Fantastic talk. I know we're out of time, so I'm going to try and make this quick. Can you go back to the 4 provincial split among?
I will try very hard.
Yeah, it's around I think slide 20 or something. It was cannabis-related adults. I don't know if it was admissions or hospitalizations, but I was here. So what I thought was somewhat confusing is I'm looking at the Quebec graph. And so far at this conference, we've kind of been praising Quebec because they've had pretty strict rules around cannabis. But it looks here like they have the highest rates of hospitalization. Am I interpreting that correctly?
Yeah, so
And
Quebec,
can you
if you
unpack
look
that more?
here, Quebec
Yeah.
has, their axis is ranging from 0 to 30. Ontario's ranging from 0 to 8. You're dealing with major structural problems and data comparability across the different provinces. The Quebec data comes from the Quebec hospitalization data for adults is coming from a different data set. I could talk all day about the nitty gritty of how terrible Canada's data infrastructure is. We're a federation of all these jurisdictions. I worked for the Public Health Agency of Canada during the pandemic on COVID work, and no one's reporting anything consistently. They have no legal obligation to do it. They use different codes. They the whole thing is a total mess. So again, the caveat that I would say when you look at data like this is that the internal comparison within its own province, if they haven't undergone a coding change, is probably pretty good. The comparison of saying, hey, hospitalizations in Quebec way higher than in Ontario, we have different data sets that we're using. Ontario has a specialized mental health bed data set that's not available in this study. So that's one of the reasons. There's different coding practices there, different health system capacity. So I would take it all with a grain of salt. And that's why, I'm not looking at this and going, hey, huge causal inference to come of this. Lots of challenges. The poisoning data, it's much easier. It's, you don't have different databases that adults are getting admitted to a specialized hospital in this one and an acute hospital there. It's just acute care hospitalizations for young kids, and it's really straightforward.
Yeah, okay. Thank you so much.
No problem.